So before starting, I request Dr. Ashwini Uttam to please introduce our chairperson as well as our speaker. Ashwini, please. Ma'am, good evening. Deepika, ma'am, good evening. You are muted, ma'am.
Thank you, sir. Good evening, everyone.
Good evening, madam.
Welcome to today's virtual CME. Myself, Dr. Ashwini Uttam. I am practicing neurologist at Kanpur. First, who has provided me this opportunity. It's my pleasure to introduce our chairpersons. We have Dr. Atul Agarwal. He is consultant neurologist Lucknow. Sir has earlier served as a professor in neurology. He has a special interest in epilepsy. We have Dr. Deepika Joshi. She is professor in neurology at IMS BHU. And ma'am has interest in stroke and movement disorder. Am I audible?
Yes, you're audible.
Okay, thank you. For a neurologist, not a single day go without seeing a patient with seizure or epilepsy. So we have a speaker, Dr. Sudhir Agarwal, who will speak today on the epilepsy clinician perspective. Sir is practicing neurologist at Smriti Hospital, Saharanpur. Sir is practicing for last 43 years. He has his MD in medicine from KGMC Lucknow in 1979. Sir had thesis on
Ashwini, where are you? I think Ashwini has disconnected. These are technical glitches which are unavoidable sometimes. So I think I must take over the things. So we have, yes, Ashwini is again here. Ashwini, unmute yourself, please. Ashwini, please unmute yourself. Yes. Now.
Yes, sir. Yes, sir.
Yes. So I think
so
we
now
should.
I hand over to chairperson.
Thank you,
Sir,
Dr.
Atul, sir,
Ashwani.
To start today's session.
Thank you, Dr. Ashwani. Thank you, Dr. Arvind, for hosting this meeting and encouraging people to join. And I know Dr. Sudhir Agarwal for so many decades. He's been senior, but yet he's a very friendly, very human, very gentle, and he's neurologist by practice and by action. He may have a neurology degree, but we all know his special interest in neurology from the very residency days in medicine. And so epilepsy remains difficult. Yesterday, I was attending a session of Indian Academy of Neurology where Dr. Robert Fisher, Stanford Epilepsy Center, was speaking. And I feel that after attending every such session, few of my doubts are cleared and I feel more transparent, more knowledgeable. But still, with every session, I have more questions to ask. And so, as a doctor, we keep learning till our last days. And I am very interesting to listen what Dr. Sudhir Agarwal will be telling us as a physician's perspective. So please, Dr. Sudhir Agarwal, present your things and then we'll have ample time for discussion.
Thank you, Dr. Atul Agarwal and Dr. Arvind Kankane. I am thankful to all of you, especially Dr. Arvind, for inviting me to give a talk on epilepsy. He has given me the opportunity to discuss the subject of epilepsy, which is very dear to my heart. All of you know about epilepsy. I'll just try to revise our old knowledge. I'll be discussing the topic in few steps. What is epilepsy? What is not epilepsy? Why we should treat it? Its classification, clinical picture, investigations, treatment, and some special situations. I'll be taking these steps step by step.
Sir,
Now,
please
first,
share your screen. Sir, if you have PowerPoint, then please share your screen.
no, I don't have a PowerPoint. I'll be speaking only.
Okay, sir.
So, epilepsy is a paroxysmal and transient disturbance of the function of brain, which develops suddenly, ceases spontaneously, and exhibits a conspicuous tendency to recur. This definition was given long back by Russell Brain in 1951. Recurrent seizure is epilepsy, everybody agrees to it. It is one of the oldest diseases known to the humanity. Seizure is a Latin word, seize, means to take possession of. The word epilepsy is derived from Greek word epilepsia, which means to seize. Although originally regarded as a disease entity, it is a symptom of many diseases. However, there still remains a large majority of the patients suffering from idiopathic epilepsy, that is for which no cause is yet known. But recently, idiopathic epilepsy, some genetic factors are being recognized. Now I'll be discussing few points about epidemiology. 50 million people are suffering from epilepsy worldwide. These are 2016 data. Some reduction in disease burden has happened between 1990 to 2016 due to reduction in case fatality. More common in low socioeconomic countries. 80% of the epilepsy patients are from low and middle income countries. Annual incidence is 45 1 lakh per 1 lakh in high income group countries. And low and middle income group countries, 81.7 per 1 lakh population. This difference could be due to perinatal injury, infection, and birth trauma. Epilepsy is associated with increased mortality, ranging from 1.6 to 9.3. The term SUDEP, sudden unexpected death in epilepsy. It accounts about 8 to 17% of deaths in epilepsy. Relatives should be counseled about this little risk of sudden death with the patients, so that the importance of treatment is being given to them. Seeing the large burden of disease, we have to treat it. It is a treatable condition, and every physician must be well versed with it. There is a large treatment gap. So many people are not taking treatment. Maybe about 30%, even more in our country. Now I'll discuss briefly about the classification of seizures. Classification of seizures and epilepsy syndromes have undergone several changes since the first attempt to classify was held in 1960. Then International League Against Epilepsy gave a classification in 1981. They divided into partial and generalized seizures. Partial into simple and complex partial seizures and various generalized seizure types. It remains the most popular scheme till date. The new revision of this classification was done in 2017 by International League Against Epilepsy. They classified into 3 varieties: focal onset, generalized onset, and unknown onset. Focal onset, patient may be aware, may have impaired consciousness, may have motor onset, automatism, atonic, clonic, myoclonic, tonic, and epileptic spasm. And non-motor may be autonomic, behavioral changes, cognitive, emotional, and sensory. In generalized onset, motor, tonic, clonic, and myoclonic. In non-motor, absence seizures, which is popularly known as petit-mal epilepsy. And third variety is unknown onset. It may be motor, tonic, clonic, epileptic spasms. The most common variety of focal seizure is temporal lobe epilepsy, which everybody knows. Past history of febrile seizures in the childhood, and then the person remains seizure free. Then at the age of 15 or 16 or 20, they develop this temporal lobe seizures, in which they get epigastric sensation and other autonomic phenomena, and then they develop a seizure. And generalized seizures, the most common is absence seizures, tonic-clonic seizures, myoclonic seizures. Tonic seizures, atonic seizures, and now I'll give few examples of common epilepsy syndromes. Benign epilepsy, centrotemporal spikes. This is a benign condition in childhood. It has got a very good prognosis. Then another variety is juvenile myoclonic epilepsy, most common in young adults and more common in young girls. So we have to be careful in selecting a drug. We should not give valproate, which is very toxic, and especially to the girls. Then epileptic encephalopathy, infantile spasms, West syndrome, Lennox-Gastaut syndrome, genetic epilepsy with febrile seizure plus syndrome, Dravet syndrome, hot water epilepsy. These are different variety of syndromes. One should know about it because the treatment is different. Now I'll discuss few things about etiology. 2017 ILAE classification about the etiology. Etiology, that there are certain structural abnormality. When there is a structural abnormality on imaging, like perinatal ischemic injury, minor and major malformations, traumatic brain injury, neoplasms. So there is a structural abnormality on scanning. Then genetic defects can lead to epilepsy. And common variety in our country, like CNS infection, the commonest is neurocysticercosis, tuberculosis, HIV, herpes simplex virus, cerebral malaria, subacute sclerosing panencephalitis, toxoplasmosis, congenital infections, immune. And this part is very important because these are treatable, like neurocysticercosis, tuberculosis, tuberculomas. And in these cases, after the treatment, the patient is cured. Then metabolic causes, sometimes acute hypoglycemia can present as epilepsy and other metabolic disorders. Congenital infections, immune-mediated epilepsy. Now, after knowing about this etiology, now we'll discuss about the clinical presentation. In clinical presentation, history is the most important. History by the patient. Patient may tell about the symptoms prior to the fit or after the fit. He may not remember what has happened. So the history is most important by the eyewitness. Eyewitness will give us the correct history. Sometimes the relatives, they make a video and we can see the video, and that we can decide whether it is a epileptic seizure or non-epileptic seizure. So if the relative, they tell there is a frothing from the mouth, tonic-clonic movements of the limbs, tongue bite, passage of urine, fits during sleep, and fall leading to injury. All these things points towards a organic origin. We have to differentiate between a fit and faint. Sometimes the patient falls like micturition syncope, psychogenic syncope, vasovagal. So we have to differentiate whether it is epilepsy or not epilepsy. So this is a thing which is important, whether patient is suffering from epilepsy or not suffering. What is not epilepsy? Sometimes there is a real difficulty in differentiating between a psychogenic seizure. If the event happens in front of you, it is most likely a psychogenic. Patient can produce it. Young girls having some psychogenic problems. Sometimes there is a real difficulty when the patient is having both organic seizures on the top of it, some psychogenic seizures. The patient is on treatment. The organic seizures are controlled, but psychogenic seizures are not controlled. So you have to treat that part also. So it is not a resistant epilepsy, it is both the things. So this condition sometimes occur. Then we have to do the physical examination. Physical examination is very important. General examination, neurological examination, fundus, skin examination. Skin may show coiffillous spots or subcutaneous nodules. Systemic examination to exclude some systemic disease. If the patient is having tuberculosis, we can find by the clinical examination, we can suspect. So the examination is equally important. Then we will go to the investigation. Investigations may not be required in all the patients, but to support the diagnosis. We can do EEG, video EEG, magnetoencephalography recently, and then second part is neuroimaging. Neuroimaging, CT scan, MRI scan. MRI scan is the most popular and common investigation done for the patients of epilepsy. If the patient can afford, one must do an MRI to differentiate between a tuberculoma or neurocystic sarcosis or temporal lobe abnormality like mesial temporal lobe sclerosis or atrophy. So the MRI is the most important imaging today. Then functional MRI, PET scan, SPECT scan, some invasive investigation which are not usually required. So after the investigation, when we are sure that the patient is suffering from epilepsy and we can clinically decide that it is which variety of epilepsy, tonic-clonic or myoclonic or absence seizure, then we have to decide the treatment. The treatment is mainly anti-epileptic drugs. One must have a knowledge of commonly used drugs, and without knowledge of the drugs, one should not use that. The oldest drug was phenobarbital, which was introduced in 1912. Before that, bromide used to be used. Then phenytoin, carbamazepine, oxcarbazepine, sodium valproate, levetiracetam, lamotrigine, topiramate, and so on. So one must have a good knowledge of the drugs, and one must be very careful about the toxicity before starting, and treatment patient should be concerned about the drug side effects. Drug should be started in a small dose, and one must tell about the importance of drug compliance. Drug compliance is the most important thing. We should give little more time to counsel the patient as relatives that disease is treatable. You have to take long-term treatment, as patients are taking treatment for diabetes, hypertension, and so many other diseases like that. It should be taken. So patient, you have to make that treatment is important. Sometimes the physician fail to address the importance of treatment to the patient and their relatives. So this is very important. Then we have to have a good knowledge of toxicity. Like older drugs like phenytoin. Phenytoin is quite a toxic drug. I just tell you an example of one of my patients. She was taking, a young lady was taking long-term phenytoin. She was on phenytoin and she developed frank psychosis. She was left by her husband. The parents, they brought her to me. They were not ready for any investigation for drug level or anything. So clinically, I made a diagnosis of phenytoin-induced psychosis. I withdrew the drug and gradually substituted with carbamazepine. In 3 months' time, she recovered completely. She became a normal person, was back to her husband. So this is such a simple thing which can be done by only clinically. And like valproate can also cause psychosis. One of our colleagues' wife was given valproate for late onset seizures, and she developed frank psychosis. And we were not able to, after some time, we realized that probably she's having these symptoms of psychosis due to valproate. Then valproate was withdrawn and levetiracetam in a small dose was introduced. She recovered completely. So these few things are very important. And then we'll discuss women with epilepsy. This is a topic in itself, but I tell you briefly, because of the childbearing age, the lady in a childbearing age should be given a drug which is safe in pregnancy. Phenytoin or valproate should be completely avoided. Levetiracetam, carbamazepine, lamotrigine are relatively safe. There is some risk with every drug. Even without drug, there is a risk of congenital anomaly, and folic acid should be added to the, and we can start even folic acid before the patient is expecting a pregnancy. And as small dose as effective should be given And if she is taking a phenytoin or valproate, if she is planning pregnancy, it should be withdrawn before pregnancy and should be given a drug which is safe. But during pregnancy, you should not withdraw the drug. There is a risk of seizures, and seizure can lead to miscarriage. Another condition in females, the periods during menstrual period, this is called catamenial epilepsy. They may get seizure during period. So for that, we can give Diamox prophylactically 1 day prior to the periods. And so other drugs, like we have to be very, very careful about the drug toxicity, because most of the drugs they causes, older drugs, especially phenobarbital, phenytoin, they causes vitamin D deficiency. So these drugs should be avoided. Now, we should, I just tell you, sometimes one of my own patient who was not, when the patient is not getting controlled, we should revise our diagnosis and think carefully that some other disease may coexist. One of my patient was having seizures in childhood. He was not getting controlled. So one day he fell down. So I asked for a CT scan. CT scan showed lot of calcification. And we discussed it with an endocrinologist, and he came out to be suffering from hypoparathyroidism, and his vitamin D levels were come, parathyroid levels were down. We substituted with vitamin D and calcium. He improved, and anticonvulsant drugs were reduced. This happened last month only. So one has to be very careful. And drug compliance, psychotherapy to the patient, they must be encouraged to take treatment properly. Some parents, they don't send their children to schools for the risk. He may have damage to the brain by learning. It heralds the learning ability. This is not true. The children should be encouraged to go to the school. Sometimes the school also refuses to take such children. So they should be advised, and even the school person should be given the advice that the child is fit to join the school. The children must be encouraged to go to the school. They must be told that they can lead a normal life. Adult people can lead a normal life. They can marry, have children, and can lead a normal social life. Depression and other social stigma, we should counsel them about that. And we can, to encourage them, we can tell the names of certain personalities who had epilepsy, and they did such a tremendous job, like Sir Isaac Newton, Napoleon Bonaparte, and a cricket player like John T. Rhodes, all had epilepsy, and they did such a commendable job. So the social stigma should not be there. So there is another drug. There is another thing, when to stop treatment. The treatment is long, and this is a very difficult question. 60 to 70% of the remission occurs for 3 years in 6, and 68% for 5 years over a period of 9 years. When we withdraw the drug, slowly 60% may have relapsed in 5 years. So it's a very difficult thing when to stop treatment. One in a child who is having seizure free for 3 years, who does not have any risk of a recurrence, we may gradually reduce the dose and can stop the treatment. So these are the things. Dear friends, this is a very common problem. Everyone must be well aware of this disease. It is a treatable condition. We should not have, a lot of people have got a lot of stigma, bhoot, pret, all this. So there is a treatment gap. So treatment gap should be reduced, and we should try to give them drugs which are cheaper, easily available. Their doses are simple. So with these words, thank you very much for the patient listening. I invite questions and comments from my friends and colleagues. Thank you so much.
Very good. Thank you, sir.
Very good overview of the epilepsy in general. But in today's world, we are so tuned to PowerPoint presentation that I felt little bit disappointed. And
I
if
agree with
you,
you.
so we expected little bit more of uh, you can message things better way with PowerPoint written things. So
That I
try
agree.
next time with the
Next time
PowerPoint.
I'll be
So
doing on
before
PowerPoint.
my comment and questions, I'll hand over to Dr. Deepika for further discussion, for her comments and further discussion. Dr. Deepika, please.
Yeah, yeah. Thank you, sir. The overview was quite elaborate and very informative, but yes, definitely, because in the PPT we have the take-home message and the highlights on, because it's such a vast topic if we consider the epidemiology, then the now recently about the classification, the ILA has nice position papers in which they for the childhood onset and the adult onset epilepsies, and a lot of nomenclatures have also changed. It's difficult to memorize, but yes, they do emphasize on a three-tier system in which a syndrome identification is usually the way to go ahead, because if we are able to identify the syndrome, then we can prognosticate and proceed accordingly, especially in the childhood onset epilepsies, those with who are which are rather benign, as we had those which was earlier called as the Rolandic epilepsy and the other occipital epilepsies, and then the with the intermediate prognosis, and then we have those with the bad prognosis. So yes, definitely, as sir mentioned that the first step should be we should try to classify the seizure, the and the get the epilepsy syndrome, and then we should decide about the treatment. So uh, we can then there are these issues of these pseudo seizures or these non-epileptic seizures, and this drug refractory epilepsy, and how you're going to give the how long to give the anti-seizure medications. So like I would like to ask one thing, how does he treat his these women with epilepsy, and especially someone comes with a myoclonus, juvenile myoclonic epilepsy, and there's a lady. So how do you, sir, approach that case? Because we have levetiracetam with a lot of psychiatric issues, and then we have to see the seizure control, and many times these patients come, they have not told, their in-laws have not been told that the lady is having seizures, and if they stop the medication, then again it's like it's very catastrophic for them. So, sir, how do you counsel, or how do you handle those cases? The juvenile myoclonic epilepsy, a young lady in a reproductive years and not yet started the family. So how do you counsel those patients? Like, how do you approach?
Yes, we counsel them. If we give them medication, they can be controlled. Valproate we avoid, and usually I give levetiracetam with good results. But one can use lamotrigine also, but I usually use levetiracetam. So far, I have not encountered a single patient of psychosis after levetiracetam. But of course, every drug has got a potential. So we try to use as much as a small dose, which is effective. And of course, we counsel them. Then this disease is not infectious. This disease not going to go into the child into the offspring, and they can have a normal life, normal married life. But it is better that it should be told to the in-laws before marriage, so that further psychedelic problems don't appear. So hiding and not disclosing that that lady girl is suffering from epilepsy is not correct. So it leads to matrimonial disharmony later. So usually I give them levetiracetam with good results, and I have not yet encountered a patient with serious toxicity or any offspring with congenital anomaly with levetiracetam.
And sir, what is your experience? Because nowadays, like we see a lot of patients who are presenting with a new onset refractory status epilepticus. Often they come to the casualty, young individuals, this nausea and fires, these new entities which have come up. So, what is your experience of treating this? Because if there is a timely intervention, then they have a it's very rewarding to treat them. So, and I would like to ask the other speakers also their experience in treating Norse and the fires category, those who are coming very explosive onset seizures, and so how your experience and the outcome in whatever patients you have treated.
This new onset seizure or person coming with status epilepticus, I'm sorry, I just forgot to mention it in my talk. Status epilepticus usually occurs with sudden withdrawal of the drugs. Person who is already having epilepsy, they are on the drug, they suddenly withdraw, they can land them in status epilepticus. So usually it is done in emergency or in casualty. So the drug of choice, we give them intravenous lorazepam, and previously we used to give diazepam. Lorazepam has got very good response, and then we can give phosphenitrine or short-acting barbiturate like pentothal sodium. So usually we give this, and of course the supportive treatment. It gives good results.
Yeah, I would like to ask the other panelists their experience in treating these acute onset, these patients coming to the casualty and preceded by febrile illness or plus minus, and then they have this explosive onset of seizures, and you may get something on the MRI. And so, how do you people go about managing these patients? Because from our experience, whatever we have seen, many times when we send for the autoimmune panel, it comes out to be negative. But yet the patients are in an encephalopathy, and they have got focal neurological deficit. They have uncontrolled seizures. So we have a series of few patients which we would soon be publishing. So in them, we have seen that if once the infection panel is ruled out, the CSF and the other viral markers. So giving these immunosuppressive drugs like methylprednisolone, IVIG, followed by immunosuppressive drugs like cyclo or rituximab. So these patients have a good outcome, and we had around 7 such patients, and everything was negative in them. Because we do need once in a while, and these patients have no previous history. The MRI is also non-contributory, or you could find some temporal hyperintensities. So we've had a good response, and otherwise they had become totally like E1, V1, M1. And then when we are giving these immunosuppressant drugs, so even in the seronegative cases, if otherwise there is no contraindication to giving these drugs, so I think they should be given, because we can really salvage young patients with epilepsy, because ultimately they have a good outcome if they are treated promptly. And in addition to the anti-seizure medication, immunosuppressive treatment should be given. So that's an important subset of patients which we have been seeing over the past 2 to 3 years, in addition to the routine cases which we see in the OPD. Yeah.
Definitely, ma'am. We do sometimes found patient with seizures having autoimmune etiologies. So there must
I'm
be.
talking about the seronegative. Yeah, when the autoimmune panel is negative, but yet if it is seronegative, we go ahead with immunosuppression.
Yes, definitely. Even in seronegative patients, even suppressive treatment may help in these patients. But is there any guidelines for starting immunosuppressive treatment in these patients?
When we reviewed the literature, so there was one paper in which they have described of around 7 to 10 patients. So they have just described the outcome in seronegative. So that is why I had said it's a very low level of evidence. There is no RCT, no guidelines. But if a patient is coming, so we have to rule out all the infective panel has to be ruled out, and any sepsis of any type in the body has to be ruled out. And after thorough and stringent screening, only do we go ahead with these
Yes,
drugs.
definitely,
So
ma'am.
has to be ruled out. Yeah.
Yes. So, sir, you have not discussed anything about surgical treatment of epilepsies. Nowadays, epilepsy surgery is also very common. One is very easily localized in focal onset seizures. One should always go for evaluation of pre-surgical evaluation for epilepsy surgeries.
Yes.
So please just say a few words about epilepsy surgery.
Yes. I'm sorry I did not mention that. I tried. I had to do it. When the seizures are not controlled with two AEDs on adequate doses, then we consider it as a resistant epilepsy. And usually, then we refer them to tertiary epilepsy centers. They evaluate for the focus, and if they remove the like temporal lobectomy and other surgical procedure, and it is very, very effective and very helpful in resistant seizures. One can go for epilepsy surgery. Nowadays, it is being done at different like PAIMS and other centers. And I agree. I'm sorry that I did not mention it. I should have mentioned it.
I think in India also a lot of persons are doing
Yes.
surgical treatment of epilepsy, epilepsy surgeries.
Yes.
Even I think VNS is also doing, persons are also doing VNS.
Because
Yes,
nervous
sir.
stimulation, yes, people are doing this also. Actually, epilepsy is such a vast topic.
Yeah, one thing before labeling as drug refractory, I think first the workup is
Workup
very
is
important
required.
in identifying. So first of all, we have to rule out the non-epileptic seizures because quite a number of times we are not sure. So if any patient comes to us with that he's not getting cured or the seizures are repeatedly happening, we should always inquire, is it the same seizure type which is occurring? Because the pseudo seizures or the non-epileptic or the functional seizures, they may occur de novo. They may occur in a patient who has had past history of epilepsy, has now started having, and it could be superimposed. It could be any situation. So first of all, we must, what we do in OPD, because long-term video EG is not very commercially feasible. So we tell them to make a home video. And in fact, there was one study from AIMS where they have shown that home video is also equally. If you're having any doubt, and if you feel that you are giving the drug to the patient, and despite that, they are not the seizures are not getting controlled, always ask the patient to get a video recording. So and then you should once he or she gets a video
Yes,
recording,
home video is definitely rewarding.
yeah, so you should corroborate that whether the seizures what they are describing or what they were previously they are still because erroneously we may refer them to a tertiary care center and it may turn out that they are all having pseudo seizure. Then secondly, the epilepsy syndrome must be identified. Many times we've seen that even when our residents see like juvenile myoclonic epilepsy or some, so they have been giving these sodium channel blockers, no, so they will also aggravate, and we may find that the patient is never cured, he goes on throwing seizures, so we may think, oh, this is. And thirdly, in the elderly patients, this complete heart block, because though there are these differences between seizures and epilepsy, that incontinence is not there, and but aisa nahi hai. The incontinence may happen even with this syncopal attack with the in the complete heart blocks. It doesn't rule out. So we have to be very, very careful in these subset of pain, especially in the elderly. So an ECG, intermittent sick sinus syndrome and all these things should be ruled out, because we have seen patients on 3, 4 anti-seizure medications, and then again they were having repeated attacks, and a few tonic-clonic movements, uprolling of eyes, incontinence does not rule out a syncopal attack. So when we are referring the patient, we should be very, very careful. So we should rule out the functional seizures. We are correct with the epilepsy syndrome. There are no mimickers. We rule out, and the elderly, all these cardiac causes must thoroughly be ruled out, because even the higher centers who are doing the epilepsy surgery, they are high pressed for time. Then they will just give a date and they will just and lastly, one thing I would like to emphasize: compliance should be checked, because often these patients come, they will say, no, we are taking the drug. But when you sit down, you will find somewhere or the other that they are missing doses of drugs. So these checklists should be there before labeling any patient as a drug refractory epilepsy and referring to the higher center. So these are practical points, simply because ours is a poor country, and in this limited settings, we have to manage the patient. So this thing should be checked at least 3, 4 times before referring the patient to a higher center. That
I'll join Dr. Deepika. Basic things. 2017 new classification we are trying to adopt, but still we are so tuned to previous nomenclatures. We still fastly write CPS.
yes,
So
true.
today partial has been taken over by focal,
Correct.
and simple and complex has been taken over by aware
Aware and
or unaware.
awareness.
Oh, but still, we are so fond of this CPS things, which is still 30 to 40% patients have that sort of thing. So one is this, that we should gradually shift to the newer classification. In that, there's another category, unclassified, unknown. So unknown shows our ignorance, but with investigations, with further investigative finding, EEG, imaging, it can become like a patient presenting with generalized seizures at night time, and then you do get a focal abnormality in EEG, or you get a focal glasses scar, or maybe SOL, and then it immediately becomes focal to to generalized tonic-clonic. The secondary word has been taken. Okay. So this type of we should adopt to whatever new classification has been given. There's a chances that in coming time they'll revise it further for
Yes.
simplification also.
Mm.
So that is one. And then many times a patients often give more importance to generalized presentation, and this focality is often picked up by video EG or a observer who have been keenly observing the patient. So because generalized to focal, the treatment is likely to differ. So this is the practical issues, and that is fine. Carry on further on.
Sir, as
Very
Deepika ma'am
important.
discussed that home videos are a number of times home videos are important in defining focalities or generalized seizures.
And pseudo Caesars.
And pseudo
It
seizure
is
also, yes,
important,
definitely.
very
Yes.
important for pseudo Caesars.
Yes.
It should
And
corroborate
sir,
with the intent, which, yeah.
unclassified opens the field of further classification. So,
Yes. Why mentioned a word fit or faint? This is very important, especially in old age when Dr. Joshi mentioned. I do get some patients who are having intermittent block and they faint and injure themselves. So injury does occur, especially in old age. There is a risk of even subdural hematoma or intracranial hemorrhage. So we have to, I always ask for them for an ECG, so simple, and then we see that pulse rate is 40, 34, and then we go for a pacemaker and then recover. This is quite common, not uncommon. So one in especially in old age with having other comorbidities like hypertension, diabetes, smoking. Say the heart block patient, they quite often come ki chakkar aa gaya, gir gaye, and then we discover. So ECG is important in such cases, and pulse rate. Even nowadays, everybody is being given this pulse oximeter. We are taking pulse. So pulse is very important. It indicates, of course, for a neurologist, pulse rate is very important. It is a sign of raised ICT. So, and one can fall then, like Dr. Joshi mentioned. So this is important, and that is why we always again and again stress on history. Proper history itself can tell us that to differentiate between a seizure or a fit or a pseudo seizure, and witnessed by the physician or by the relatives or video is very important. Home video.
Yeah. And I would say like there are 2-3 important points in history taking. First is the age of presentation is very, very important, and then
Yes.
the duration of illness. So we always emphasize to our residents always to mention that, so that when the patient comes in the follow-up, because the age of presentation, the total duration, that determines later on when we are considering a drug taper. And of course, there are some syndromes in which you cannot withdraw. That's beyond the point. But in those where you can consider, and apart from that, the birth history should be taken into account, and how the disease has progressed. Now, if it is isolated seizures going on with a fairly good control, so we may consider. But if something else, apart from the seizures, if some cognition, gait, some movement disorder, something else has crept into the scenario, then we should start thinking of some genetic etiology or something else. So the treatment planning and the tapering of drugs and how to go about all these factors should be taken into account. What other symptoms have stepped inside, while, or is it isolated seizures, or is it some cognitive involvement, some other seizure type, some other system involvement has crept in, neurological or non-neurological. So these factors become very important. And then what is the total duration? When, क्योंकि patient comes to OPD, he says कि 3 साल हो गया, अब हमारा drug तो कब बंद होगा? So that is the first and foremost question. So then we have to explain all that, head injury present or not, birth injury present or not. So all these factors are taken into account whenever we take the decision of introducing any drug or tapering, and when we are planning to finally withdraw the treatment after the patient has been free or in remission for 3 years.
Any other question from the audience? Or
I would like to make 2 comments into my. There are 2 queries from my side. Am I audible?
yes,
Yes.
yes, you're audible.
I do agree with Deepika madam. The patients which presents with new onset super refractory seizure, they don't respond to anti-epileptic drug alone. You have to add immunomodulation, whether it's steroid or IVIG, irrespective of their autoimmune profile. I found many patient autoimmune profile was negative, but they responded only to when you added to this immunomodulation therapy. Second, comment is that you can miss a seizure, but you can't afford a syncope. A few months back, I had an elderly gentleman who came to me with frequent falls. What I found, he had AF. I started on anticoagulation and asked him to go to cardiologist because there is no current neurological issue. He did not had stroke at that time. What happened, he went to cardiologist started on antiarrhythmic drug and rate controlling drugs, calcium channel, but they stopped anticoagulation, and he suffered from massive posterior circulation stroke. So recurring loss of consciousness, most of physicians thinks that it is a seizure and start anti-epileptic, but it should be emphasized that syncope or cardiogenic cause should be ruled out. My queries are 2. One, if suppose the patient, you diagnose the patient with epilepsy, and he cause of epilepsy is the inflammatory granuloma. You treat it, and after 6 months, you get a scan, and you found that inflammatory granuloma has gone, whether NCC or tuberculoma. So how long, and he did not have recurrence. So how long anti-epileptic therapy should be given? Minimum period. Should be 1 year or 2 years. And my second query is there any dedicated epilepsy surgery program in Uttar Pradesh, apart from NCR, in Lucknow or BHU? If anybody knows, please tell me.
If I have to answer the first question, then I'll say that if it was a benign syndrome because of a probably cysticercus, and it has been treated for 6 months and repeat scan and file is fine. You can taper the drug even after 6 months. So shorter duration of treatment is fine. But in some patients, when you repeat the scan, there is a calcification or even glasses around. So these patients have a little more chances of recurrence. So if I have to treat, I'll treat them for few more months, maybe a year, and then I'll tell that this calcification will remain lifelong and need not repeat further on, and one should try to taper. Good number of them, 90 to 95% are remain seizure free, but a small percentage in various series may have recurrence, and then they could be for longer period of anti-seizure medications, maybe many more years, 3 years, maybe even 5 years. And in some patient, maybe even 10, 20 years, maybe lifelong. Because when you try to withdraw or reduce, they have a recurrence. So this is the first question. Yes, there's no dedicated unit in Uttar Pradesh as per my information. People at Sanjay Gandhi PGI and at KG Medical University, they've been trying for last few years to build up. They have operated few cases. They are a good team. That means a good neurologist for that and neurosurgeons to that. But it has not picked up as much as it should have been. I keep sending some of my patients who could not go to Delhi or even Trivandrum, and some of two have been operated. but is not as per expectation. Dr. Deepika, your comment on both the questions.
Yes, as regards the first one, there have been studies where even tapering 6 months, 8 months, 1 year have been done, and so that has to be actually individualized. If we are not getting a calcified lesion, but the patient has to remain in the follow-up. If suppose there are in certain professions, like that is what we follow. If suppose the patient is a bus driver or he's something in the with the this Air Force, like something of these professions. So in these group, I am a bit skeptical. I usually prefer a longer duration. And even when I'm tapering, I tell them very carefully, it's written on the OPD slip that if you find any, wherever the lesion was located, if you find any sensory symptoms in them, I do a slow taper. And I tell them if there is any sensory, motor, any subtle symptom, any warning signs, you come immediately, and then we'll have to restart the medication, especially if they are in a dangerous profession, or where they are in some public dealing where they may endanger the life. Because many times it happens that CT, if they get it done, if the slices are thick, a small lesion, it may show it has completely, the resolution is there, but then that's there on the MRI, but very subtle lesion may be missed. And if there is a calcification, then I definitely treat for a longer period of time, a minimum period of 3 years. And after that, again, I tell them in the follow-up that see, because all these drugs, they do not prevent the epilepsy recurrence, whether we are giving albendazole or steroids, whatever, though they do prevent the short term, the seizure control and all is better. So if a calcified lesion is there, then again I give her at least for 3 years, and we ask the patients to remain in follow-up. And if at a later date the seizures are recurring, then again we have to analyze the cause, because we had a patient of, it can be both ways. This patient had a cysticercus, and it got cured, and then the patient was put off drugs. It was completely, there was a resolution. Then again he came to us, and this time he had developed a different seizure type. So he had developed early morning generalized seizures with a myoclonus. So it was a juvenile myoclonic epilepsy. So here also we should not be very relaxed that okay, 3 saal ke liye diya jao. Maybe nothing prevents a person of having a cysticercus lesion in the, because our country is endemic for all these infectious disorders, and later on he may develop one of the idiopathic generalized epilepsy syndromes also. So it has to be, I think there is no one answer. It has to be individualized, case by case. If the profession is dangerous, so in 6 months, though there are studies on that, but I personally never withdraw, even if the lesion has completely vanished in 6 months. So a minimum of 2 years, and then case by case, I individualize. If the patient is educated, can come and the follow up, the parents are educated, then but I always write on the OPD slip, and also and it's better we get an MRI done. And MRI resolution is always better, because CT, sometimes it may be missed. They're very small lesions. And as regards the epilepsy center, yeah, we're referring the cases to AIMS, but our faculty is also, we are planning, we are in the process, and we are trying to coordinate. So hopefully in the next 6 to 7 months, we should be out with this, because unofficially in the lesional epilepsies we have done, we also have a neurosurgeon, but that as a epilepsy unit, that full-fledged monitoring unit, and then that comprehensive epilepsy surgery program with a social worker, psychologist, neurosurgeon, that whole team is not there. But yes, we are trying, and we should be able to do within the next 6 to 7 months. So currently we are referring to AIMS, New Delhi.
Thank you, ma'am. Thank you very much. I think there's any questions from audience? So I extend my sincere thanks to Dr. Sudhir Agrawal sir for such a nice and informative talk. And I also extend my sincere thanks to both our chairpersons, Dr. Professor Deepika Joshi ma'am and Professor Atul Agrawal sir. And also Dr. Ashwini Uttam for moderating this session very nicely. I request Professor Dr. Atul Agrawal sir to do the honor of Dr. Sudhir Agrawal sir. Although virtual honor, because we are at the virtual platform, so virtual honor of Sudhir Agarwal sir.
Beauty of Dr. Sudhir Agarwal is that he is present in every neurology meeting. If we have any program in Lucknow, he'll be there. He was there with us at Dehradun last UP UK
Yes, sir.
conference. So we appreciate your love and your heart with the neurology, and we honor you, sir, with this. We present you in absentia the flower bouquet and this certificate of appreciation from Dr. Kankane and Vivek Sharma.
Sir.
And thank you, sir. And we give a clap.
Thank you
And
so much.
this,
Sir, we will deliver this
Thank you so
certificate
much.
in physical form in our upcoming conference at Lucknow, which is going to be organized by SGPJ Lucknow.
Okay.
So we'll deliver your physical certificate in that conference.
Thank you so much.
Thank you, sir. Thank you for delivering such a nice talk. So
thank you so
everyone
much, everyone.
Thank you everyone for joining with us and staying with us.
Thank you for the patient listening and the comments, especially Dr. Deepika Joshi and Dr. Atula. And I've taken the note that I'll be in future be presenting with a PowerPoint presentation. Thank you so much.
Thank you, sir. Thank you very much.
Namaskar, sir. Namaskar.
Namaste, sir.
Namaste.
Thank you, sir. Thank you, Kumar sir.
Thank you so
everyone
much
for joining with us.
Thank you. Thank you, everyone.
Thank you, sir. Amitabh, sir.
And it is such a nice meeting all of you. So virtually not, I'll be visiting Jhansi. So I'll meet you there.
Sir, definitely, sir.